thank you very much for the invitation to come along today. Really interesting to hear that we're a little bit light on data and health informaticians in the room, so I do hope that this talk will be informative and hopefully interesting to you. Much of my work really focuses on making the best use of routinely available clinical and healthcare data. And this is data at both the individual patient level, but also at the population level. And I'm going to talk this morning about some work and a program of research we've been doing using this routinely collected clinical healthcare data to look at sepsis detection and also to evaluate sepsis detection screening tools. So I'm a statistician by training with a background in immunology. And I lead a team of data scientists, statisticians, and epidemiologists who are really focused on harnessing the power of real-world data. And we can do this in a number of ways. We can use these data to model, to quantify, and risk stratify patient populations. We can also use these routine data to evaluate interventions once they've been implemented into the healthcare system. And I'm a statistician, so I'm really interested in doing robust evaluations, so thinking about things like randomized controlled trials. But being aware that often interventions, as we know, are implemented into healthcare systems without any kind of clinical experimental design. But policy changes, we respond to that. So often we're working in the realms of what we call quasi-experimental or natural experiments. As a statistician, I want to improve the robustness of my evaluations, so we use a lot of causal inference methodology, which I'll talk a tiny bit about. And finally, we can use these routinely available data to drive innovation and intervention development themselves. And I'll talk about some of the work we're doing around developing algorithms, particularly transparent, explainable, real-world algorithms, as well as some of our work on clinical decision support tools. And it's worth mentioning that all of my work is funded through the National Institute for Health Research. So although I'm very data-focused, every piece of research has to translate into an improvement or a benefit to patient within 5 years of completion. So although I'm quantitative by nature, we very much have the patients at the heart of our story. And I'll talk at the end about some of the work we've done in collaboration with quality improvement teams in NHS trusts. I don't need to highlight here today high on the healthcare agenda, highly topical sepsis associated with rapid mortality and extremely difficult to diagnose, as you guys know, in a busy hospital environment. As I mentioned, the National Institute for Health Research began by funding this program of work through their biomedical research centres based at Imperial NHS Trust, also at Royal Marsden and the Institute of Cancer Research. And really what we wanted to do was to see if we could use real-world healthcare data to evaluate digital tools that were in use in Imperial NHS Trust for the early detection of sepsis. So to give you a flavour, our trust covers 5 hospitals across northwest London, treating on average of 2 million patients per year. The trust is part of an academic health science centre and is also a partner in a biomedical research centre. So around the time of this work, about 2018, 2019, as I'm sure you're very aware, in 2015, 2016, there were sepsis targets introduced to improve sepsis screening in secondary care across the nation. And trusts responded to these targets in a variety of different ways. Locally at Imperial NHS Trust, the introduction of these targets coincided with the introduction of the first electronic patient record system, or EPR, provided by Ceire. Now, within Ceire, there was embedded a digital sepsis alert. So we thought, okay, for the first time we have access to this granular individual patient level data. Can we use these data to evaluate the impact of implementing this Ceire digital sepsis screening alert on patient outcomes? And we were really interested in whether it changed patient mortality, a patient's length of stay, or whether it had any implications in terms of antimicrobial receipt and therapy. And again, for the first time, and this was super exciting for us as statisticians, we had access through this digital EPR for the first time of individual patient level data, so highly granular minute-by-minute data that gave us a complete picture of a patient's hospital stay. So for the first time, we had information on diagnoses, lab data, patient demographics, procedures, lab tests, medication, and prescribing. And we also had this time-stamped, so we could literally trace a patient's journey through our hospital network. The sepsis screening tool that's embedded within Cerner, as I'm sure many of you know, is based on the St. John's sepsis algorithm. It looks something like this. So 3 or more evidence of an infection response, i.e. elevated temperature, heart rate, resp rate, white blood cell count, or glucose, is associated with a suspicion of sepsis alert firing within an individual patient's EPR. If these are combined with evidence of organ dysfunction, as listed in the box, the box on the bottom of the screen, this would trigger a suspicion of severe sepsis alert within the patient's EPR. And we implemented this digital sepsis alert in a phased approach across our hospital trust and in different parts of the hospital at different times. So this is just a timeline. What I'd like to highlight here, if I can, is that you can see there's a grey period of time at which time there's an alert, and then the colour of the timeline changes. So essentially, during this grey period, the digital alert was firing in the background. It was being recorded on an individual patient's EPR, but it was invisible to clinicians. At a specific time point then, the alert was switched to live, at which point, again, the alert would fire if appropriate, but this time the clinicians could see the outcome and behaviour could change. So what this gave us was a quasi-intervention and a quasi-control group. So the visible to clinicians stage of our timeline is our intervention period. When the alert was running silently and not visible to clinicians, it was in the control group. And this set us up in what we like to term as a natural experiment. So not quite an RCT, we don't have randomization here, but nevertheless, we have a sort of control population. And again, for the first time, we had this highly granular individual patient level data. So we were able to think about this as a natural experiment using individual patient information. So we had over 21,000 patients over an 18-month period. We had all this rich data about them. But I just want to stop for a moment and remind ourselves of kind of EPI 101. So we do know that in the hierarchy of evidence, a synthesis of randomized controlled trials is the gold standard for changing clinical practice and implementing new tools or drugs or whatever the intervention might be, followed by a randomized controlled trial. Within a natural experiment, so the approach and the evaluation methods that we were using, we're thinking about this as a controlled experiment. And what that might mean is that we have imbalance between our intervention and our control group. And in fact, that's exactly what we found. So we found that we had fewer elderly ladies in our intervention group. We had fewer elderly men in our control group. So there was that imbalance that usually a randomization process would account for. So what that means is that we were able to utilize some statistical methodology to improve the causal associations that we could determine from our evaluation. So essentially, we use this method called propensity score weighting. It's known as a doubly robust procedure. And what that does is it allows us to adjust our analysis for the fact that there's this imbalance between our groups. And what we found was that when we conducted our evaluation using our individual patient level data, the introduction of the digital sepsis alert within Imperial NHS Trust was associated with a reduction in risk of in-hospital mortality over a period of 30 days. It was associated with individual patients having a reduced risk of an extended hospital stay. So that was defined as 7 or more days. And it also improved the likelihood of that individual patient for receiving timely antibiotic therapy. And we conducted all of this analysis specifically looking at those patients who were in the emergency department. So we do appreciate that there's a cohort of patients who've had a longer stay in hospital and suddenly deteriorate. They're not included in this particular analysis. So really a bit of a local success story for our trust. We implemented this EPR, it had this digital sepsis alert, it was associated with these positive outcomes for patients, got a nice publication and some media coverage around those results. But obviously we're thinking here, thank you, is that this is a single site study. So actually what's happening nationally? So we went back to the National Institute for Health Research, to their Health Service and Delivery Research Programme. We got a £1 million grant to essentially repeat this research, extend it beyond a single site in Northwest London in a particular population. So we collaborated with NHS trusts across England and Wales and their corresponding academic organisations, as well as the UK Sepsis Trust. And we set out with this much larger piece of work to go right back to the roots, and first of all to start by mapping what digital alerts or screening tools were currently in use in UK hospitals to identify patients at risk of sepsis. We then wanted to repeat our quantitative analysis, so evaluate the impact of these digital alerts on patient outcomes. We then had a qualitative piece because we had gained some knowledge from our quality improvement teams that a lot of this digital alert and the effects that we're seeing were really mitigated by high levels of quality improvement activity going on in tandem. So we wanted to explore how implementation approaches and were taking place in different trusts and how they might impact the effect of these digital alerts. And finally, we wanted to synthesize all of this information and see if we could make some recommendations around best practice. So to start off with, this mapping exercise, we couldn't find a lot of information around the prevalence of digital sepsis alerts or even what screening tools were being used across NHS trusts. And we started out with England. So we eventually did a Freedom of Information request, and this is a corresponding paper in BMJ Health and Care Informatics. And what we found overall was that there was no agreed evidence-based algorithm. So hospitals were using a whole variety and a wide variety of approaches, despite the fact that the fundamental screening tool was something akin to News 2. All hospitals in England were using a form of screening tool, but they weren't particularly sensitive or specific to sepsis. They generally captured information on deterioration. So we were thinking back to our study at Imperial, and we were thinking, well, we have these powerful EPR systems. They've got lots of information we could draw on. Perhaps we could define something and make something that's a little bit more appropriate for different patient cohorts. And what we had found in the course of that mapping exercise is that many trusts, whilst they said they were using a digital sepsis screening tool, it was simply a digital version of something that had been paper-based, so maybe 3 or 4 key variables. So something that was quick to use but had been directly translated and wasn't drawing on or harnessing any of these data that we have available to us. Despite the hype, at the time of this study, we didn't find any evidence that predictive AI or machine learning was being used. And then there was this issue that a lot of trusts were using kind of black box algorithms, so proprietary algorithms. They weren't quite sure. We've done a little bit of research on the side, and I'm sure people are aware, for example, of the EPIC sepsis screening tool. Often these algorithms don't have any validation, let alone any clinical evaluation. So we don't really know how they're operating on in terms of patient outcomes. So bringing all of this together, we kind of summed up that digital alerts, which could access a patient's detailed EPR, could have the potential to include a whole lot of really useful information around comorbidity or even age that could be tailored to patient histories and lead to better diagnosis and better treatment. The second part of that work was to then look at a number of different trusts and to repeat our quantitative evaluation. So look at the impact of digital sepsis alerting on mortality across multiple trusts, so repeating what we had done at a single site at Imperial. And here we found really mixed results. So I'll just go into it in a little bit more detail here. Essentially, anything that's falling, the forest plot here shows that any lines that are falling to the right of that dotted line indicate that the alert was associated with a reduction in mortality. Now you can see that of the 4 trusts I've shown you here, there's only one clear signal coming from one trust that the alert was associated with a reduction in mortality. So really mixed results overall when we looked at our patient populations. And again, we put this down to sepsis tools being neither sensitive nor specific, being quite generic and quite general, and capturing information on deterioration. What we did see is that when we stratified these analyses, some of these screening tools and alerts perform much better in different patient populations. So generally speaking, in older age group populations, they were associated with a reduction in mortality. So this is a whole cohort analysis, but it sort of led us to think about how we could tailor things for different patient populations. And one of the key things that came out of our work was to think about specific diagnoses and conditions that patients already have, such as cancer. So we know that sepsis is a frequent complication in immunosuppressed patients. Patients with cancer are at far greater risk of acquiring sepsis. They spend longer in hospital. They have more invasive procedures. The nature of the therapy itself can put them at risk. So none of these factors are currently included in sepsis alerts. And these alerts really aren't sensitive for this patient population. And this was borne out in the data. So I'm just showing you 1 year's worth of data from North West London from Imperial NHS Trust. So 26% of our patients that alerted had a cancer diagnosis. These patients were more likely to have a blood culture confirmed sepsis diagnosis, although there were so few of our patients who actually had a blood culture confirmed diagnosis. These patients were generally administered an antibiotic, Coamox or Pip/Taz, and we also found that they had a higher prevalence in those cancer patients who alerted who had a blood culture confirmed. There was a higher prevalence of having an antibiotic-resistant pathogen identified in their blood cultures. So bringing that into the fold and thinking about some of the research I've done in the past around judicious use of antibiotic therapy, we know that antibiotics are the cornerstone, and judicious use of these drugs is a cornerstone of AMR prevention strategies. And we know that overexposure to antibiotics is associated with an increased likelihood of a subsequent AMR infection. We know that there's a relatively high number of our cancer patients who are alerting, and certainly our St. John's sepsis algorithm isn't specific for this patient population. And we also worryingly know these patients are more likely to have a resistant pathogen. So again, adding this to the data that we had from the mapping exercise, we believe that if we are to use risk stratification tools and translate those into digital sepsis alerts, they really need to be sensitive and specific to the patient population that we're trying to help. And again, this is summarizing the findings across the whole studies. We found that there was this differential response according to age and comorbidity status. We found that the majority of English hospitals had an EPR system, so we know the data's there, and we're using some kind of digital sepsis screening tools, but these were relatively simple and weren't harnessing the wealth of data that we now have available to us. We also have this issue of off-the-shelf proprietary algorithms. We know often these haven't been validated, let alone evaluated. And again, banging home this message that detailed data from an EPR could be used to improve digital sepsis alerting. So what have we done next? We're currently at the next phase of our research where we said, okay, we have all of this learning. We've now got a relatively large HRA-approved research database. So we have individual patient-level data for over 1 million patients. We have all of that highly granular EPR data, time-stamped what was going on with patients at every minute of their hospital journey. And we have that for a number of large teaching and foundation NHS trusts, as well as cancer specialist hospitals in England and Wales. So essentially what we want to do now is we want to develop an algorithm to be translated into a sepsis alert using this rich EPR data and using the methodologies that we know of as a team, as data scientists. We want to validate this algorithm in external data sets. And finally, we want to use an experimental design. So bring in randomization and actually clinically evaluate really robustly the impact of the introduction of any kind of algorithm in terms of patient outcomes, again, being interested in mortality, length of stay, and IV antibiotic treatment. So this work is currently being led by a PhD student, Alf Timney, based at Imperial and the Institute of Cancer Research. And he's developed a novel transparent machine learning algorithm that's using ED data from our database to predict sepsis. So we're using retrospective data that we've collected from our work to date. And we're using this method called Shapley value approximations. So essentially what this does, it creates an explainable machine learning algorithm. So for example, as clinical folk, you will be able to understand exactly what variables are coming out of that algorithm at what time. So it's not this kind of black box, press a button, who knows what happens kind of approach. And we've actually developed 3 models. We've developed a shallow neural network, which would be a kind of black box style approach. And then we have our second SHAP approximation model, and we've further refined that. We've trained and tested the model in multiple NHS trusts data. We've also tied in with the NIHR BRC Health Informatics team to further aid validation of our algorithm. We had 28,000 patient spells with just under 9%, including a sepsis diagnosis. And what we found is that our third model, which is the refined SHAP approximation model, performs just as well as the shallow neural network. So essentially, we've got quite good sensitivity and specificity in terms of predicting sepsis from our model. So we think this might be a feasible approach to detecting sepsis at the earliest time point using ED data. It's explainable to clinicians. We know that we can embed it within EPR, and we know that all the data is there, so it's not requiring any extra information to be collected. We've conducted internal validation and external validation. We're also validating it in a Danish data set. And we've just set up a cluster randomized controlled trial to embed this within the EPR system of 2 large NHS trusts. So more to come on that, basically. We've also been working on taking the same approach and using ED data, this time in helping patients manage neutropenic sepsis. So this is a slightly different outcome of interest here. Currently, patients are advised to come to hospital if they're feeling unwell during chemotherapeutic treatment. But research has shown that 1 in 2 patients have normal neutrophil levels. They didn't need to attend hospital. They didn't need to receive IV antibiotic treatment. And this accounts for about 50,000 avoidable A&E attendances in the NHS annually. So we've been working with a company on a point of care test, which is a pinprick test that looks at CRP and neutrophil counts at different thresholds. This can then be taken to ED, combined with patient information from their EPR, and we're looking at the predictive ability of those 2 combined biomarker and EPR data pieces to predict whether or not a patient should be admitted with suspected neutropenic sepsis. I just want to sum up really, because there's not a lot of data people in the room, and I really want to recognize the fact that any of the work that I've spoken about in terms of using real-world healthcare data really is dependent on synergy and collaboration with clinicians, health informaticians, patient voices. None of this work would have been possible if we didn't sit in on our weekly quality improvement teams in our sepsis big room at Imperial NHS Trust, because that is how we understood how the data were generated, the quality of the data, how we could feed back on quality of data, and it became this nice virtuous cycle. So I really want to highlight that this is very much a kind of group exercise. We've published on this if anyone's interested in learning more about these types of collaborations and working in this way. And I just wanted to highlight as well that really crucial to the work we do, I don't have an NHS contract. I work with patient data. I work with anonymized patient data within secure data environments and trusted research environments. And that infrastructure is just crucial for the type of activity and the work that we want to do. I'll stop there. This is the team involved in the DIAL study, so the multi-site evaluation. And I want to say thanks and acknowledge them, and the smaller team of statisticians and data crunchers who've helped me with some of the analysis. And thank you guys for listening.